Good afternoon. Welcome to the renal session. My name is Tzvi Bar-Sefer from Israel, and co-moderating this session with me is Anita Brink from South Africa. I'd like to invite our first speaker, Monica Rosley from Sydney. The title of her presentation is Imaging in the Assessment of Urinary Tract Infection.
Thank you, Tzvi. So urinary tract infection is a very common problem. In England, 3.5% of girls and 1.2% of boys have had a symptomatic infection, and data out of Sweden showed that the cumulative incidence at 7 years was 7.8% of girls and 1.6% of boys. But despite this being such a common clinical problem, the role of imaging in the evaluation of children with urinary tract infection remains controversial. So I just want to review some of the recent literature to assess the role of imaging in this patient population. Now, the main reasons for imaging are to prevent further episodes of febrile urinary tract infection, to diagnose obstructive malformations, mainly posterior urethral valves and PUJ obstruction, because infection in obstructed systems is very problematic. They become very septic. To diagnose dilating reflux, that is greater than grade 3 reflux, which may result in renal scarring. To diagnose congenital kidney abnormality, which will be abbreviated like that in my talk, and to identify cases with potential evolution to end-stage renal disease. So this is why we image. Now, prenatal, this is from a review article that was published in the New England Journal of Medicine, and these authors, Montini's from Italy, Tues is from England, and Ian Hewitt is from Perth, Western Australia. And they wrote this review article on febrile urinary tract infections in children. And they acknowledge that prenatal ultrasound studies are identifying children with congenital renal anomalies and reflux, and that scars may occur from primary renal damage in utero. That is, for example, prior obstruction or developmental factors that precede the urinary tract infection, but scars may also develop following the infection. Now, 60% of children with febrile urinary tract infection have defects on DMSA scintigraphy, and we do know that that does correspond to acute pyelonephritic scars from animal data, and that 10 to 40% of these kids will have permanent renal scarring on DMSA studies performed distant from the infection. This is data from Sweden. And this is an amazing study. It's a prospective study that went over between 16 and 26 years. And the aim of their studies was to evaluate the long-term risks of infection-related scarring, as these were not well understood. They followed children with non-obstructive renal scarring and non-scarred kidneys 16 to 26 years after their first urinary tract infection. And they found that children with unilateral scars or those without scars had similar renal function on follow-up, but that children with bilateral scars had lower renal function, and that the GFR was significantly lower in this group on follow-up. There was no difference in ambulatory blood pressure readings, and this is one of the few prospective studies that have been undertaken, and they actually show quite a low rate of long-term consequences. Several retrospective studies have suggested that renal scarring after urinary tract infection carries a clinically significant risk of chronic kidney disease in up to 20% of children, hypertension, and preeclampsia. But the problem with retrospective studies is they may be limited by referral bias to specialised centres. That is, only kids with the most severe infections and problems may be referred to specialist centres. So what is the best approach in evaluating a child after the first febrile urinary tract infection? And as I've said, this remains contentious. The main imaging methods that are utilised are ultrasonography, cystograms and DMSA scintigraphy. Now with ultrasonography, this is a great test. It's non-invasive. It can reveal a variety of anatomical abnormalities. However, it does not reliably detect reflux, pyelonephritis or scarring. And 70% of renal and urinary tract abnormalities are detected antenatally on ultrasound. So if a child presents with a urinary tract infection, some workers advocate ascertaining whether a reliable normal ultrasound study was performed during the third trimester of pregnancy, and if it's available for review at the time of infection. If it's not available for review, then you should perform a urinary tract infection, an ultrasound. Ultrasound is also indicated if the urinary tract infection is atypical, for example, non-Escherichia coli, if there's a delayed response to antibiotics, if there's an abnormal stream, recurrent infections or renal impairment. Other workers advocate that all children under 2 years after an initial febrile urinary tract infection should have an ultrasound. Now, the cystogram is the most controversial investigation, and the number of cystograms that are being performed now are less than they were years ago. Some workers advocate performing cystograms in all children after their first febrile urinary tract infection. Other workers advocate a more selective approach, that is in children with atypical features, abnormality on ultrasound, poor stream or renal impairment. But a selective approach may miss some children with clinically important reflux until another infection occurs. There's an international grading system for classifying reflux. Grade 1 is just into the ureter, grade 2 reaches the pelvis, and from grade 3 to 5 it's gradually increasing dilatation. So here's an example of a positive cystogram. And you can see there's reflux into both kidneys, but in the right kidney you can see there's intrarenal reflux as well. So that the contrast is not only going into the calyces, but it's also going into the renal parenchyma. This is not covered in the international classification, and some workers feel this is a worse prognosis because if this system gets infected, it's more likely that the bugs will get through at sites of intrarenal reflux, but we have no way of reporting that on the international classification. This is a reason for performing a cystogram in a boy who presents with urinary tract infection, because this boy has got a dilated proximal urethra, and here is the posterior urethral valve, and it's very important to diagnose this obstructive problem early to reduce the risk of renal damage in the future. These valves they cut them and get rid of them. Now, the concerns about cystogram is the radiation burden involved. The actual dose the kid gets depends on the technique used. There is associated pain and distress, and there is a risk of introducing an infection, especially in a child with high-grade reflux. This is the DMSA scan, that planar images on the top, pinhole below, of a child who presented to our emergency department septic after having had a cystogram the previous 24 hours. He had urosepsis and he had multifocal pyelonephritis in both kidneys. You can see all these defects in both kidneys are as a result of the cystogram, which revealed high-grade reflux. So these kids can actually die from sepsis following the cystogram, and in dilating reflux there's a strong argument to give a dose of antibiotics after the procedure. Now, what is the association between urinary tract infection and reflux? 30% of children with infection have reflux, and reflux may predispose to upper tract involvement with infection. But acute pyelonephritis frequently occurs in the absence of demonstrable reflux. Andrew Rosenberg from our hospital showed that in children who had a positive DMSA at the time of urinary tract infection, only 24% of them had reflux demonstrated on the cystogram. Masood Madj from Washington Children's Hospital found that 37% of these children had reflux, and Ditchfield from the Royal Children's Hospital in Melbourne had an incidence of 39%. So just because there's upper tract involvement with infection doesn't necessarily mean that reflux is present. Now, it is established that there's an increasing incidence of scarring on DMSA with increasing grades of reflux, and that low-grade reflux has a low incidence of scars. This was demonstrated by Dr. Farnsworth in our institution, and as well as the Swedish group, Dr. Stockland from Sweden. So there's an apparent paradox that on an acute DMSA performed at the time of urinary tract infection, there appears to be no relationship between the presence of reflux and acute pyelonephritis. But on a late DMSA scan performed distant from the infection, the incidence of renal cortical scarring is related to the grade of reflux. And I think the explanation for this paradox is that a lot of these children have got antenatal damage. Now, DMSA scintigraphy, this is the third investigation we use in investigating these children. There is a radiation dose involved, which raises concern in the clinical setting. DMSA can be used to confirm the presence of upper tract involvement with infection, or it can be performed to determine whether residual scarring has occurred following the infection. Now, the literature suggests waiting 6 to 12 months from the infection to overcome any transient effects from the infection. But a lot of paediatricians don't want to wait that long when they're managing their children. We'll wait a minimum of 3 months to call a scar because it's basic pathological principle that it takes 3 months for healing. So a small kidney with uniform uptake likely represents antenatal pathology, and a focal defect with loss of contour likely represents an infection-related scar. Now, the Swedes advocate a top-down approach. They do an acute DMSA at the time of urinary tract infection. If the DMSA is normal, their level of concern is less because the kidneys have not been involved. But if the DMSA is abnormal, that's when they perform a cystogram, and this protocol certainly decreases the number of cystograms performed. There are a number of guidelines for performing renal cortical scintigraphy published by EANM. They're in the literature. So the minimum dose is 30 megabecs and scaled up to body surface area with a maximum of 120. Imaging protocols, about 1/3 of the injection is excreted via glomerular filtration. So you inject and then you scan about 2 to 3 hours later because you don't want the radio urine in the picture. If there is hydronephrosis, you may need to do delayed imaging. The minimum views to perform are posterior views and posterior oblique views to look at the anterior aspect of the kidney with high-resolution parallel hole collimator. In our institution, we like to also do the pinhole using a 2 to 4 millimeter aperture. They take about 10 minutes each. SPECT can also be performed, but our clinicians aren't interested in a tiny little defect seen on SPECT alone. That's not going to influence their management. There is a paper in the literature showing that in 10 patients who had no history of renal disease, no infection, no hypertension, small defects are seen on SPECT, and this may be just due to normal cortical variation. It is more technically demanding than pinhole, and with kids, motion artifact can be a problem. So in our institution, we like performing the pinhole rather than SPECT. What does a normal DMSA study look like? You get homogeneous cortical uptake with low concentration in the collecting system. The DMSA is taken up by the tubular cells in the renal cortex. You can get varying scan appearances. One is flattening in the supralateral aspect of the upper pole of the left kidney due to splenic attenuation, and you can get prominent columns of Bertan on the scan. So here, these are planar images. These are two normal kidneys and his normal pinhole, and you can see this normal rim of renal cortical uptake. In this one here, there is some prominence of the columns of Bertan, but that doesn't impede your interpretation of these kidneys being normal. What kind of computer analysis can be done? Differential function estimates and renal length measurements. Now, the guidelines say in children you only need to do the posterior view. You can also do geometric mean to compensate for differences in depth, but in children that's not usually an issue. Occasionally there may be a more anteriorly displaced kidney. We routinely measure renal length measurements because on DMSA it's very clear to see the upper and lower pole, and we've devised a nomogram here of normal renal lengths. Most of our kids that are scanned are young, so the standard deviation is tight in the young age and it's not so accurate in the older age. And if you compare the nomogram on DMSA to the nomogram on ultrasound, in general in nuclear medicine we measure about 0.5 to 1 centimetre longer than on ultrasound, and there are two reasons for that. When we acquire the DMSA, we acquire the image for 5 minutes, and there's going to be respiratory excursion, so the kidneys are going to move up and down. And on ultrasound, the child has to take a deep breath in and hold it to get that maximum longitudinal axis, and sometimes they're not so cooperative in taking. So, we generally measure a bit longer than ultrasound. Now, this is what I was talking about here, the left upper pole. Years ago, 4 doctors in Sydney involved in paediatric nuclear medicine decided to review 300 DMSA scans, and generally there was excellent concordance, but there were a few cases where we couldn't agree. And this was one case where there's this quite prominent impression here in the left upper pole. 2 out of the 4 thought this was a prominent splenic impression, and 2 of the 4 thought this was a cortical scar. And we don't take the kidneys out in these kids, so we don't know what the right answer was. You can do the DMSA acutely to look for pyelonephritis or chronically to look for scarring. And as I said before, we wait at least 3 months, but some advocate waiting up to 12 months for any acute changes to resolve. Now, we do know from animal data performed at Washington Children's Hospital by Dr. Majd and also by the Great Ormond Street Group, they confirmed that the changes on an acute DMSA using the pig model did correspond to acute pyelonephritic foci. At our institution, we mainly use DMSA to look for chronic cortical scarring, and so we decided to validate that in the animal model using the pig. And Dr. Farnsworth was the urologist that I worked with. And these are Dr. Farnsworth, the urologist. This is a few years ago, as you can tell, and Di Layton was the radiologist who did the ultrasound on these pigs. Now, the problem was that we would get the pigs when they were little, and we would do a baseline scan to make sure they had normal kidneys. Then Dr. Farnsworth would induce reflux by laying open the ureteric orifice. We would do a cystogram, and if the cystogram was positive, we'd put some E. coli into the bladder. We would then do an acute DMSA, and when that was abnormal, he would go back in and take out that nidus of bugs, and we would put them on antibiotics, and then we'd send the pig to a pig farm for 3 months to wait for acute changes to resolve. The problem is these pigs put on 0.5 kilo a day, and by the time they came back to us, they were 120 kilos, which is not your usual sized child. But anyway, we compared planar, pinhole and SPECT. and we had only induced reflux and acute pyelonephritis on the one side, using the contralateral kidney as a control. And after doing the scans, we took out the pig's kidneys and they corresponded exactly. This was the normal kidney that looked normal on the DMSA, and this was the scarred kidney. I would draw in where I thought the scars were, and the pathologist would draw in where he found the scars, and they corresponded exactly. So we're quite confident that when we call a scar on DMSA, as long as there's not an infection in the close proximity, then they're scarred. What are the different scan features? In acute pyelonephritis, you can have unifocal pyelonephritis or acute lobar nephronia, multifocal or diffuse. And acute features are areas of focally decreased or absent uptake without cortical or volume loss. The renal cortical outline remains intact. So here you've got a unifocal pyelonephritis or acute lobar nephronia. The child was given antibiotics. 3 months later, the kidney returned to normal. This is a multifocal pyelonephritis. Here, these areas of reduced uptake. The child was treated, and you can see on follow-up that kidney remains normal. And this is a diffusely involved kidney with diffuse abnormal uptake. It resolves on the 8-month scan, no residual scarring, but on follow-up, that kidney's not growing as well as the other kidney. So what are the features of renal cortical scarring? On those previous scans, you could still see the outline of the kidney, but in this kidney, you can see these cortical defects with loss of the normal renal cortical outline. So this is an extensively scarred left kidney. Here's there's scarring on both kidneys, this left lower pole, but in this right kidney, the upper pole is normal and the lower pole is quite scarred. This child had reflux into the lower pole component of a duplex, and that's a classic appearance of scarring of a scarred lower pole of a duplex with a normal upper pole. CT and MR have got very limited application in kids with urinary tract infection, but may be performed if there's a question of intrarenal abscess or if there's a delayed response to antibiotic treatment. Now, in seminars in 2014, workers reported febrile urinary tract infection, clinical diagnosis, imaging and prognosis. And one of the papers that they quote in this article is a really interesting paper that was published in Pediatrics, where they compared different guidelines for imaging after the first urinary tract infection in febrile infants, comparing yield, cost and radiation dose. So they compared 5 different guidelines: American Academy of Pediatrics, the NICE guidelines from England, the top-down approach from Scandinavia, the Royal Children's Hospital Melbourne guidelines, and the Italian Society of Paediatric Nephrology guidelines. I'll refer you to this article. It's in seminars, but this table basically summarises the findings. At Royal Children's, all the kids have ultrasound. They will do a cystogram if there are features of concern either clinically or on ultrasound, and they don't advocate performing a late DMSA. On the NICE guidelines, they'll only routinely perform an ultrasound if the child's under 6 months of age, because younger kids are at higher risk, and they'll only perform a cystogram if there are abnormal findings on ultrasound or atypical features or both, and they'll only do a DMSA if there are atypical features. If the child's over 6 months, they don't routinely recommend an ultrasound. Now the Swedes, the top-down approach, all will have a DMSA, and the DMSA will determine if they're going to have a cystogram or an ultrasound. The American Academy of Pediatrics, all kids get an ultrasound. Some get a cystogram if there's abnormality on ultrasound, and none of them get a DMSA. And the Italians all get an ultrasound, some get a cystogram, and some get a DMSA. So all the guidelines except the top-down approach recommend ultrasound as the initial imaging test. All restrict the use of cystogram to selected cases, either with positive findings on ultrasound and atypical infection or other risk factors, or positive remarkable findings on DMSA in the Swedish guidelines. All limit late DMSA scans to cases with atypical infection or positive ultrasound or positive acute findings. And the Royal Children's Hospital and the American Academy of Pediatrics do not recommend late DMSA. So, comparing all these guidelines, the NICE and the American Association of Pediatrics have the highest specificity for reflux. The Italians have the highest specificity for detecting scars. As could be predicted, the NICE guidelines have the least cost, and the American guidelines have the least radiation exposure. The top-down approach from Sweden has the highest sensitivity for detecting reflux and scarring, but also has the highest economic and radiation cost. And they conclude that there's no ideal diagnostic protocol following a first febrile urinary tract infection. An aggressive protocol has a high sensitivity for detecting reflux and scarring, but carries a financial and radiation cost with questionable benefit, arguing that a lot of damage is done antenatally. And there is a lack of consensus as to the protocol to be used due to the uncertainty regarding the long-term clinical significance of reflux and urinary tract infection-related scarring. Renal damage previously attributed to acquired pyelonephritic scarring is now recognised as being more commonly congenital in nature. So that was the conclusions of this paper. I just want to, two other papers. This one here from the European Journal of Urology. There's yet no consensus as to whether a kidney or bladder-centric approach is preferable for initial imaging. This was from the Perth group, and they analysed pre and post NICE guidelines, and while they found there was a definite decrease in cystograms and prophylactic antibiotics, there was an increase in the number of DMSAs, which was counter to the NICE guidelines, and they felt that this was because clinicians needed the reassurance of a normal study given the reduced number of cystograms and prophylaxis. This paper said, don't worry, we're going to calm the storm, but concluded that there was still ample confusion. So I just want to end by saying that I think the guidelines that you should use in your hospital, you need to meet with your clinicians, and we meet every week and determine what's appropriate in their referrals in your centre. Thank you.
Thank you very much, Monica, for this excellent presentation. In the interest of time, please remember your questions and hand them over at the end of the session during the panel discussion.
Dr. Bosserve is now going to talk to us about guideline development.
The Atlantic Ocean separates not just the continents of North America and Europe, but also two lines of thought regarding the best way to perform diuretic renography in children. The current guidelines, the SNMMI guidelines, are from 2008, and the European guidelines from 2011. Both are a bit outdated, although there were no major revolutions in this field during these years. So we set up quite an ambitious project at the Pediatric Committee of the European Association of Nuclear Medicine. We approached the Pediatric Imaging Council of the SNMMI and said, why don't we try to unify our diuretic renography guidelines in children, because currently it's a mess. People are confused, there are conflicting recommendations. So it was sort of unbelievable, but this is what we were able to achieve. And right now there is a guideline. It's not published yet, but it's really in the pre-publication phase, meaning that it underwent all the revisions and all the comments from both continents. And what I'd like to do today is to present you some highlights from this new harmonized guidelines. Before doing that, I'd like to recognize the two key authors of these guidelines, Professor Masoud Maj from the SNMMI side and Dr. Diego Di Palma from the European side. Here are the topics I'll be discussing, and in red you'll see some aspects where the new guideline had new information or corrected previous informations, etc. So starting off with preparations, and perhaps the most important part is obtaining adequate hydration, because it is essential for optimal post-furosemide diuresis, and it also prevents dehydration. And you can achieve hydration orally in cooperative children. You give them age-appropriate volume ranging between 300 and 500 mLs, and you can also achieve that by giving IV fluids. And this is mandatory in patients who cannot or will not comply with oral intake of fluids. The suggested fluid volume is 15 to 20 ml per kilo. 2/3 is better given prior to furosemide administration. The type of fluid is dependent on the hospital institution's policy. And nevertheless, regardless of the way of hydration, you should record in your report, and mention even in your report, the amount of fluids that were taken. So basically, both routes of hydration are acceptable in the appropriate setting. This is sort of the recommendation of the guideline. Now, as far as emptying the bladder, it is important to empty the bladder and to minimize the effects of the full bladder. The rationale is that high intravesical pressure can delay drainage from the renal pelvis and ureter. A huge bladder can also compress the distal ureter, causing a so-called pseudo-obstruction. When you have a full bladder, there is a higher frequency of reflux that can confuse the drainage pattern. And also, a full bladder may result in premature termination of the study due to the need of the patient to void. So obviously one way to empty the bladder is the spontaneous way, the physiologic way. Toilet-trained children should empty the bladder before acquisition. Children willing and capable to void into a urinal without moving in the supine position should be encouraged to do so during acquisition. This is sort of new. And spontaneous voiding is mandatory for the late post-gravity assisted image. So if you can't achieve earlier voiding, then definitely for the final image, if you get there, you need this to be a post-void image. The other way to empty the bladder is by bladder catheterization. However, the guideline states that this should be performed on a selective basis, keeping in mind the unpleasant invasive nature of the procedure and also the complications, as Monica mentioned earlier. It is especially advised in infants and children with hydroureter nephrosis, posterior urethral valves, known high-grade reflux, or a neuropathic bladder. And also a benefit of that is that bladder catheterization will reduce the gonadal dose. So basically, I know that the Europeans were totally against bladder catheterization. In North America, it was quite commonly and done in many, many children. So the guideline is a sort of compromise. Yes, you must put a catheter in, but do reserve catheter to very selective cases, keeping in mind the complications and unpleasant nature of this procedure. This is the compromise. As for the radiopharmaceuticals, there is complete agreement that tubular agents are preferred over glomerular agents, and this is because of their higher extraction fraction. It's more than twice, MAG3 is more than twice than DTPA, which results in improved renal contrast achieved with tubular agents. And this difference between the agents is particularly important in neonates due to renal immaturity and also in children with impaired renal function. The acquisition views, well, the standard view is the posterior view. However, if you do encounter a case with a horseshoe kidney or an ectopic kidney, then it's advised to perform anterior and posterior views and to calculate the differential renal function from the geometrical mean. The radiopharmaceutical dose, it shouldn't be any guesswork today. There are two very strong guidelines there. You can either use the E&M pediatric dosage card or the North American consensus guidelines. These recommendations have been harmonized, and basically they would point you to the same dose. As for the acquisition protocol, it's based on the timing of furosemide administration, but we just mentioned in these guidelines the two most common protocols, the F0, meaning that the radiopharmaceutical and furosemide are administered simultaneously, and following that there is a 20-minute dynamic acquisition. And the other one, which is more commonly used in North America, the F+20 or 30, meaning that you first acquire a dynamic study for 20 to 30 minutes, and only after that you administer Lasix and start a second acquisition of a 20 to 30 minutes. Using the F plus 2030 protocol, you should be aware of scenarios where you should modify the timing of furosemide administration. One of them being that you should postpone furosemide in cases of severely dilated collecting systems who are not entirely filled with a radiotracer after the standard 20 or 30 minutes. So wait a little bit, look again at the collecting system, and only when it's full, administer Lasix. However, also in cases where you see spontaneous drainage from this widely dilated system, you should actually, in these cases, consider giving Lasix earlier than 20 or 30 minutes, because otherwise you won't be assessing drainage under diuretic condition. And this is exactly what you need to do. So even if the kidney is draining spontaneously, if it's draining fast, and you're concerned that you won't have any remaining activity in the pelvis at the end of this dynamic acquisition, start Lasix earlier, because you want to see how the kidney drains under conditions of high diuresis. The other important part, which I'm not sure was mentioned or possibly mentioned in previous guidelines, is the gravity-assisted post-void image. If drainage at the end of the dynamic imaging is insufficient regardless of the protocol, it should be reassessed visually and semi-quantitatively after the patient is kept in the upright position for a standardized period of time. And of course, this image should be acquired after bladder emptying. So there are two options how to go around this recommendation. One is to compare between the pre and post upright image, meaning that the patient is kept in an upright position between the images for 10 to 15 minutes. Each image is acquired for 1 minute, and the post upright position image should be acquired after bladder emptying. The other way to do it is just obtain an additional late static image, a post-void image at a standardized time. It could be 60 minutes from tracer administration or perhaps later. This image should be acquired after the patient has been kept upright, so we get the gravity-assisted drainage, and it's a post-void image, and so it's actually just one static image, a late image that you're assessing. As for the calculation of the differential renal function, well, we should use for the calculation for drawing the regions of interest the images that show the maximum tracer accumulation in the cortex, and ideally none in the pelvic ileal system. So for MAG3, it's the summed 60 to 120 second image. For DTPA, if you're using DTPA, it's the summed 60 to 180 second image, reflecting the different uptake mechanisms of these tracers. As for the regions of interest, the renal ROI for the calculation of the DRF should include only the functional visible renal parenchyma. This actually means that if you are using the F0 protocol, there may be need to draw two different kidney regions of interest, one for the differential renal function calculation and another encompassing the kidney with the dilated collecting system for proper assessment of drainage. The background ROI should include counts from the liver and spleen, and I know there have been many recommendations about the type of region of interest. The guideline recommends the C-shaped background, and the most important part is to sample the liver and spleen in your background, because usually there is quite high activity, which is underestimated if you're just doing the semilunar inferior infralateral standard ROI, background ROIs. Time activity curves. First, perform motion correction. Most vendors provide you with software to do that. And keep in mind that the region of interest for generation of post-furosemide drainage curve should be drawn on images showing the maximal dilatation of the collecting system to ensure adequate representation of post-diuresis clearance by the curves. And also, this ROI should include the entire dilated system. So in cases of hydroureter nephrosis, this ROI should include both the pelvis and the ureter. In cases of hydroureter nephrosis where you are suspecting that there might be concomitant UPJ obstruction, it is advised also to draw separate ROIs, one for the pelvis and one for the ureter. As for assessing drainage with semi-quantitative indices, the guideline mentions the well-known washout half time, the T1 half, with no specific recommendations. It mentions the percentage drainage at the end of dynamic acquisition, meaning the remaining activity divided by the peak activity. And the new thing that the guideline mentions, it's new possibly in North America, but has been used for many years now in Europe, is the normalized residual activity, NORA, which is actually the ratio of the renal counts acquired for 1 minute at the end of the dynamic imaging and at the late post-void image, and the renal counts between 1 to 2 minutes. So it is actually normalizing the remaining activity with the activity present in the kidney during the parenchymal phase. And the guideline also states that this is the most robust measurement of post-diuresis clearance. The reason for that is because it is independent of the renal input. It's independent it's not affected by the renal function. So if you have a poorly functioning kidney, you would still get a good assessment using this drainage regarding the drainage. If you're using other indices, you would get a very prolonged T1/2, but that could also just reflect the poor renal function and not necessarily the drainage. As for the gravity-assisted post-void image, you assess it visually. But if you're using the pre and post gravity-assisted drainage static images, you could also draw a region of interest over the entire dilated system on both images and use this simple formula with the pre-upright counts minus the post-upright counts divided by the pre-upright counts to get a index, a numerical index. The guideline doesn't give any normal values for that. Monica, perhaps you have some, but we'll discuss that later. It's just introducing this index. And if you're just performing a late post-gravity assisted post-void image and not a pre and post, then you're basing your evaluation on visual assessment and on the NORA index that is applied on that late image. Okay, so how do we interpret those diuretic renograms? First, it is based on a combination of the revision of the images, curves, and indices. The semi-quantitative indices are interrelated to the images and should not be interpreted in isolation. This is very important because this is something the urologists often very like. They just like the numbers. They don't care about our interpretation. What's the T1/2 and that's it, which is a very wrong way to describe the study. And even the guideline addresses this and says this is particularly true for the T1/2. Now, the same protocol and data processing techniques should be employed for the baseline and follow-up studies. This goes without saying, but it's a very important aspect. On any study showing impaired drainage, the pattern of cortical transit should be noted. This is something new. I mean, it's not new overall, but it's new as far as guidelines are concerned. And the reason is that the pattern of cortical transit may raise some red flags for critical obstruction. Critical obstruction meaning that this is the kidney that, unless surgery is performed to relieve obstruction, might lose parenchymal function. An obstructed kidney, as you well know, doesn't necessarily imply that this kidney requires surgeries. About 60% of them, the obstruction could resolve spontaneously. However, some of these kidneys do have critical obstruction and will lose function. And so the cortical transit might raise a red flag about the likelihood of this phenomenon to occur. So what are the red flags? Delayed cortical clearance, which means that you calculate the cortical transit time. Again, there's no strict formula. It's roughly defined as the time between injection and the first appearance of tracer in the collecting system. And there are no strict normal values, but I would say that you usually see tracer in the collecting system after 2, 3, 4 minutes. But if it's occurring after 8 to 10 minutes, then this is definitely a delayed cortical transit time. So this is one red flag. The other one is what you see is initially good clearance from the cortex, but reaccumulation of tracer in the cortex following furosemide injection, and I'll show you an example. It also should be noted that a significant drop in the differential renal function on a follow-up study is often associated with prolonged cortical transit time, and this definitely is an indication for surgery. So I'll just finish with just to demonstrate this aspect of cortical transit, which is new as far as the guidelines are concerned. And so this is a renogram, a MAG3 study from a 1-month-old child with left hydronephrosis. This has been done with the F+20 technique. So we are just seeing the first 20 minutes before furosemide administration. And you can see the dilated pelvis here on the left. You can see the tracer clearly in the cortex, but it really takes a long time for this tracer to move from the cortex and to fill the dilated pelvis. So this is an example of delayed cortical transit time. And these are the late images, the pre and post gravity-assisted drainage image, which actually show that there is markedly impaired drainage in this case. So this would be a concerning case. I would not just say that there is impaired drainage, I would also say, yes, but there's also prolonged cortical transit time, meaning that this implies that kidney is at a higher risk for loss of function. Now, the next example was kindly provided to me by Professor Masoud Maj. And this is reaccumulation of tracer in the cortex following furosemide administration. So he also uses, I think he uses the F+30 technique. So these are the pre-furosemide dynamic images. And you can see tracer retention in the cortex, only the cortex of the left kidney before Lasix administration. Now, after Lasix administration, if you follow the images, you see something very interesting occurring. You see this tracer actually filling back the cortex. If you compare this late image to this image, and this is also reflected in the curves when there's a rise in the curve. And this is just to blow up those final images showing you tracer activity in the cortex, which is actually due to reaccumulation. So this is a red flag. And that's it. Thank you.